So I'm Tom Bergquist, and I have joint appointments in both the Department of Psychiatry and Psychology and the Department of Physical Medicine and Rehabilitation. And I do most of my work, clinical and research work, in the Department of PM&R, Physical Medicine and Rehab, where I serve as the program director for our day rehab program and also a co-investigator in our TBI Model System grant. This is our fourth successful funding cycle for this grant. It's funded by the National Institute of Disability Rehabilitation Research, which is through the U.S. Department of Education. The purpose of these grants is to do research specifically with persons with traumatic brain injury for the purpose of improving their quality of lives, finding the best and most effective treatment outcomes, and dealing with issues of disability. Well, so far, and we are not even a year into a first year of a 5-year grant. This current grant cycle started on October the 1st of 2012. So I guess that would put us around 6 months or so. And there are many elements of the Model System grant. One of them is to be part of a national database, which is, I think, the largest cumulative database of persons with a traumatic brain injury in the country. Thousands of cases, some of them going back over 20 years. So it's a rich source of information to which we contribute and from which we can use that data for research purposes to just understand and track people with more severe traumatic brain injuries. It also allows us the opportunity to collaborate with a variety of medical centers and rehab hospitals around the country, really the top rehab centers and the top physical medicine and rehabilitation departments in the country. The main part of this grant is a site-specific project, which we will be doing here. This project is, in our case, in this funding cycle, it's called the Connect study. And the idea is to work with 4 states, Minnesota, both Dakotas, and Iowa, to identify persons who've had traumatic brain injuries near the time that they experienced their injuries, and try to connect, hence the name, with both the patients themselves, their families, and local providers to help them get the best practices and the best treatments and the most up-to-date information in their home community. Now, what many people have done over the years and still do is to, pack up from somewhere in North Dakota, come down to a place like Mayo Clinic, and get that expert knowledge, which we as a big tertiary care center in healthcare would have. But for someone that needs ongoing treatment, it's really unrealistic typically, and certainly cost prohibitive in many cases for them to stay here for an ongoing basis to get that treatment. Moreover, for rehabilitation really to be most effective, it's best done in your home community. In other words, if we're helping you to be more independent with your ability to manage your own affairs, you're more effective in your ability to interact with others in your community, all of which are things that can be affected after traumatic brain injury, and to help you return to work. It's really hard to do that, from 500 miles away when all those things and all that environment is back in your home community. So what's happened over time in the last couple of decades is the whole field of telemedicine, or what it's more commonly called now is telehealth, which is providing medical healthcare services remotely to the person in their home community, especially specialized services that they might not have available in their home community, so they don't have to travel. So the purpose of this study is to interact, as I said earlier, with the persons with the acquired brain injury, their family, and their local healthcare team, to give them the state-of-the-art knowledge, give them, if not real-time, at least very timely advice on what they're doing, expertise, information, so they can get the best possible treatment available. So we are talking to people directly to see what would be the best way to connect with you and what information would be the most helpful to get, and how might we best support you in having, to make this project to be the most effective. Thankfully, for us, one of our partners in this project is the Mayo Center for Innovation, and they've been extremely helpful, and they have lots of expertise and knowledge in coming up with new and innovative ways of doing healthcare, including doing things through a telehealth kind of a paradigm, which is what we're trying to do. I can say the response we've got from those we were beginning to contact, providers and families, has been fairly enthusiastic, that I think they feel that this could really be beneficial people often use the term thinking out of the box. I think the mission statement for the Center for Innovation could be helping this large, wonderful, but sometimes hard to change institution of 35, 40,000 employees in healthcare trying to think out of the box. So they can ask questions that we never even thought of, and they can help us do things and find things that we wouldn't know where to find or would have taken much longer to find. We're in the pilot phase. We anticipate that'll last through at least the summer, and that hopefully will be, once we find out what we need to find out to get the design the right platforms and connect, again that term, connect with people the most effectively, that we could be recruiting subjects as early as fall, when we're roughly 1 year into the grant, which was our plan. But that would be the plan, to start recruiting folks through all 4 states that we're going to work with. That's Minnesota, both North and South Dakota, and Iowa. I should have added too that the people that are in this study, at least in terms of our interaction with them, we'll never see them in person. We will likely interact with them, and certainly with the providers and their families. The outcomes that mean the most to people are typically ones that involve their own home community. So doesn't it make sense that you would want to treat them to affect those outcomes right where they live and where those outcomes are best measured? So that, I think, in the end will be the, if this does as we hope it will do, that this will really be a huge advance in how we do healthcare. This will really allow us to reach people that we otherwise couldn't reach, but also to have people have outcomes that they otherwise couldn't have, and get the same outcomes we've been able to get here in clinic-based folks, treatments for people that live in our immediate region, to those people that live far away.